So we're going to switch gear a little bit from talking about therapy and then into management of some of the sickle-related complications. While these may not be the pain crises that we know that are the most common, but nevertheless, these are actually important and they are increasingly recognized to be more common. So the first is talking about blood clots, venous thromboembolism, and I'm going to welcome back Arun.
So I hope to try and tell you a little bit about venous thromboembolism in relationship to sickle cell disease, talk a little bit about its prevention, maybe show you some of the data that we have at the NIH, and then maybe touch a little bit on why venous thromboembolism occurs in sickle cell disease. And I was assisted greatly by Matt Heaney, who covered a lot of the pathophysiology. And then I'll try and touch on the management, how we try and manage venous thromboembolism. As you probably know, there's evidence-based guidelines, but the real question is, does that evidence fit to the patient population that we're dealing with? And maybe we can try and ask some questions about that. So to go first, you all know about sickle cell disease, so I'm not going to belabor the point here, but I'm going to just try and tell you that people talked a lot about hydroxyurea. We had Russell Ware give us a nice overview of how we should be using hydroxyurea. There was some coverage of GBT440, crizanlizumab, and L-glutamine. We don't have major treatments for DVTs or venous blood clotting in sickle cell disease. And so what I'm going to try and tell you a little bit about is that this is DVT and PE, which are clinical phenomena that we see in sickle cell disease. We know over the past 10 years or so that there's been accumulating data on the idea that sickle cell disease is a hypercoagulable state. It's characterized by changes in biochemical markers that suggest that the coagulation system is activated. We also know that it's associated with an increased risk of thrombosis both in the venous as well as the arterial vasculature. So I'm going to try and focus a little bit on the venous system because you all already know about the arterial vasculature, and that's not really the focus of my talk. So you can see today, there's a bunch of epidemiological data which suggests that venous thromboembolism is a common phenomenon in sickle cell disease. Most of these studies are retrospective, but what I'm going to do is try and focus a little bit on these three studies which are relatively recent. The first by Raki Naik and her group at Hopkins, published in 2014, shows that there's a cumulative incidence of 11% of venous thromboembolism in sickle cell disease patients, and this occurs by the age of 40. The identifying provoking factors were hormones, surgery, hospitalization, but interestingly, the majority were unprovoked. That is, they were not associated with something that was associated with thrombosis risk. The follow-up study by the California group was by Ann Brunson and her colleagues, Ted Woon and the others. They studied a large group of patients, over 6,000, in which they showed a very similar cumulative incidence, again below the age of 40. What you will see now is that sickle cell disease patients have an incident venous thromboembolism much earlier than the general population. So that suggests that there is greater risk for venous thrombosis. The risk factors in this study were greater than 3 hospitalizations, and women were at a higher risk of developing a blood clot than men, which is contrary to the published literature in the general population. And then finally, we have the study again by Ted Woon's group, where they show very nicely that the cumulative incidence of recurrence is high, almost 13% at year 1, and going up to about 25% at year 5. And again, the risk factors associated with recurrence were severe sickle cell disease, the presence of a lower extremity DVT as an incident event, and pneumonia or ACS. If we put VTE in perspective, I'd like to say that it's probably the 3rd leading cause of vascular mortality after heart attack and stroke. So it's an important clinical problem. And when you think about it in terms of hospital improvement implications, it's the most common cause of preventable death in a hospitalized patient. The risk of fatal perioperative PE is high at 0.08. Almost 150 to 200,000 deaths occur per year in perioperative patients. And the AHRQ stand is that VTE prevention is the #1 priority to improve safety in hospitals. So you have a good sense now that VTE, or venous thromboembolism, is an important problem in sickle cell disease. So if we look at thromboembolism prevention, how are we doing? What is the data? And you can see that the safety and efficacy of thromboembolism prophylaxis is pretty good. It's reasonably safe and it's quite effective. This again is a retrospective study of 135 adults in a single center where they could show that the majority of patients received venous thromboembolism prophylaxis, most of them, that's about 86%. There was early discontinuation in about 20%, and the reasons for discontinuation were a suspected VTE, which was the majority, and then either hemorrhage or suspected HIT, which is heparin-induced thrombocytopenia. So you can see that heparin prophylaxis is very safe and very effective. So we examined some of the data that we have at the NIH in one of the protocols that Swile is the PI of, and it looks at admitting patients with an acute vaso-occlusive crisis. So when you see the number of patients admitted in this slide, and this is data done by a really smart summer intern, Rafael Agbor Ino, who's originally from Cameroon but now lives in the US and is studying for his PharmD. So he was a third-year student who spent some time in the lab and basically looked at 60 patients, of which 32 were hospitalized, 22 had a single admission, 22 had multiple admissions, and there were 32 that required prophylaxis, of which 37 that required prophylaxis, of which 27 received prophylaxis when they were admitted for more than 24 hours. Interestingly, about 10 that were admitted for less than 24 hours did not receive prophylaxis. You can see on the right here that the majority received prophylaxis, but quite a few did not. And so it's interesting to go back and find those reasons. One of the things that we're working on. But if you think about how we can improve prophylaxis, I think one needs to target. Anyone who gets admitted should ideally receive prophylaxis, and we don't do that so well. The reason I say that is that no one knows how long a patient's going to be admitted, and we don't know whether the thrombosis risk is low if you have an admission for less than 24 hours. We know that it's relatively high because of the epidemiological data from the California study. So why does venous thromboembolism occur in sickle cell disease? I'm going to show you a little data that we had in the early days when I was a fellow in Bob Hebel's lab. Here on the left is a circulating endothelial cell isolated from the peripheral blood of sickle cell disease patients, identified in green by an endothelial-specific marker called P1H12. If you look at the stain of the same cell with a tissue factor antibody, it lights up completely, demonstrating the presence of a tissue factor antigen. Multiple papers have also subsequently shown that there is elevated tissue factor on the endothelial cell of sickle cell disease patients. SETI's work has suggested that intravascular hemoglobin may be responsible for this phenomena. If you look at the middle panel, you can see that whole blood tissue factor procoagulant activity is elevated in SC patients and SS patients compared with normal race-matched controls. Finally, on the right is additional data suggesting that in the circulating blood of sickle cell disease patients, there are endothelial as well as monocyte-derived extracellular vesicles, which are very small particles that bud off these cells, which are positive for tissue factor, both in steady state and during crisis. The majority are derived from monocytes, shown in blue, and they are partly derived from endothelial cells. These two cells, both endothelial cells and monocytes, can be activated to express tissue factor, and we know that there's evidence that endothelial cells and monocytes are activated in sickle cell disease and demonstrate markers of activation such as ICAM, BCAM, E-selectin, and P-selectin. Here's a cartoon of these tissue factor positive microparticles which have adhesion markers, cell surface markers, as well as procoagulant activity on the basis of tissue factor expression. So what does this tissue factor do? Here's a nice little cartoon by Professor Preston that basically shows that tissue factor binds in the vasculature with active 7A and can turn on 10 to 10A, which can then generate thrombin. which is another thing that Matt Heaney was talking about, increased thrombin generation in sickle cell disease. Once you have triggering of the clotting cascade intravascularly, you can have amplification because the thrombin can then provide feedback, amplification of the coagulation cascade. And once there is enough thrombin for a thrombin burst, that can be propagated, resulting in the deposition of fibrin and activation of platelets. We already know that there's good evidence for fibrin deposition in sickle cell disease patients. Here's a summary of all the clotting factors that are activated both at the cellular level, at the 10A generation level, at the thrombin generation level, both in steady state and during acute crisis, which suggests that the coagulation system is activated. So I already showed you that tissue factor is possibly an important driver of coagulation initiation in sickle cell disease, and that hemolysis and hemoglobin release into the vasculature might be the initial precursor event. What seems to be interesting is that the sickle red cell also could contribute to this phenomenon, and shown here is data from Rafal Pawlinsky's group at UNC, where they very nicely show that in the mouse model that the red cell is increased in sickle clots. These sorts of clots do not release red cells easily. The clots are very porous and they're unstable, and they have an increased fibrin content compared to clots in a healthy mouse that does not have sickle hemoglobin. This can be reduced by exchanging the mouse, or the clot stability can be improved by exchanging the mouse. And shown here is the electron microscope image of a single animal that survived this procedure, where they caused a ligature in the IVC of these mouse, and you can see that there's abnormal fibrinogen all around with an increased amount of trapped red cells, which show sickling, possibly due to the hypoxia. So if we put it all together, why do sickle cell disease patients have blood clots? All of you just stood up now, right? And you improved your laminar flow over here by increasing the activity of your gastrocnemius soleus complex. Then when you stood on your tippy toes, you pushed back more blood into your bloodstream, and that's pretty normal. Then your endothelium works really well. When you're developing a blood clot, what happens is there's some hypoxia in the valve pocket over here, which can then increase the presence of tissue factor, Pi1 or VCAM or P-selectin or E-selectin. All of that can trigger leukocyte activation, which again Matt Heaney talked a little bit about, the presence of neutrophil, extracellular traps, platelet activation, as well as tissue factor positive extracellular vesicles. And all of these can then downstream result in thrombin generation, as well as activation of the clotting cascade. I didn't talk to you about the intrinsic pathway. There's some increasing data suggesting that the contact pathway may be involved in this process. I'm not really going to go into that. I'm now going to switch very quickly to how we manage venous thromboembolism and sickle cell disease. And first, I'll show you how we try and diagnose this. I've taken some of these images from Elise Wahlberg's really nice paper, where they basically show that you can use echocardiograms, CTPA, which is CT pulmonary angiography, ventilation perfusion scanning, where you can see ventilation here, but abnormal defects in the perfusion, and then mismatched defects give you a diagnosis of a pulmonary embolism. And here's the EKG finding, where you have an S1Q3T3, which is typical of diagnosis of pulmonary embolism. But if you go here, when you suspect a DVT or a pulmonary embolism in a patient, one thinks of what's the pretest likelihood in the general population. In sickle cell disease patients, I would say that your pretest probability is pretty high to begin with. So if it's moderate or high, you go straight to compression ultrasonography or CTPA, which is computed tomography pulmonary angiography. And once you do these tests, if it's positive, you have a diagnosis of a thrombosis or a pulmonary embolism. If it's negative, you do not have evidence. The main things that I would point out to you is that CTPA is relatively safe in sickle cell disease patients because of the use of non-ionic low osmolarity contrast. And we typically do not use a D-dimer as a screening test for patients with sickle cell disease because they already have elevated D-dimers, and that's not terribly helpful. So we talked a little bit about diagnosis. We're going to talk a little bit about treatment. And so here I'm going to show you a case, and I'm going to ask you to try and give me a yes-no answer. So we have a 25-year-old male with sickle cell disease who's being treated with osteomyelitis, who develops a right upper extremity swelling. The ultrasound reveals a DVT in the subclavian and axillary vein. He has a PICC line in that arm and needs 4 weeks more of antibiotics. You start anticoagulation. Do you need to pull the line? Can I have a show of hands? Yes, I have some yeses, and then I have some no's.
Yes and no.
Yes and no. Okay, I like that. So let's walk through this. So the data obviously is already in published format, but this does not include sickle cell disease patients. So if I had a patient with a clot, I would leave the line in place. I don't think that's a problem, but I would continue anticoagulation. I would finish the antibiotic treatment course that he has, and then I would pull the line. But after that, we would anticoagulate for 3 months at least. And here's the data that supports that idea that you would anticoagulate for 3 months. There is no need for long-term anticoagulation, so approximately 3 months, and this is grade 1 evidence. So I'm going to give you the second case now, which is a 35-year-old female with sickle cell disease who comes to the hospital with worsening chest pain. She visited the emergency room for complaints 3 weeks ago and was discharged with oral antibiotics. Her CT obtained on your patient ruled out pneumonia infiltrates, but you are not certain they used a PE protocol. You repeat a CTPA and find that there is a subsegmental filling defect. Does your patient need anticoagulation? And I will take 3 answers here. I will take yes, no, or I don't know. So do we have any yeses?
Yeah.
Yes. And do we have any no's? No's. Okay. Well, my answer is I don't know. And so the data on this is, so here's the CT of this very patient. So she was called to have a subsegmental pulmonary embolism, and there it is. We have a filling defect over there, and you can see nice vasculature on the other side. This is a patient that Swile was taken care of and very kindly shared with me. Here are the guidelines for subsegmental PE. What do we think is the reason? We think that they have started from a small DVT. The clinical relevance is unclear of these events, and it's still not certain whether to treat these events or not. Sometimes the diagnosis is likely to be a false positive finding, depends on the experience of your radiologist, and the clinical management guidelines are not evidence-based. However, there are 2 trials that are pending. Mark Carrier is the one who's the PI on one of them. So the way I go about this is talk to the radiologist. If he confirms that what he sees is real, then I say, okay, fine. Is there a low risk for recurrent VTE in sickle cell disease patients? That's probably not true. Is there good cardiopulmonary reserve? Yes. Should I do a bilateral ultrasonography? Yes, I would do an ultrasound to rule out DVT in the lower legs. That was negative in this patient. Would you consider clinical surveillance? No, I would actually start anticoagulation. And the reason I say that is there's increasing evidence that patients with sickle cell disease have VTE pulmonary embolism is the initial presentation, so very often they may not have a leg clot, and a subsegmental PE, in my mind, for now, should be treated rather than watched. I would treat for 3 months.
And Swile did the right thing.
And Swile did the right thing, of course.
She did go and talk to the radiologist.
Of course, she went and reviewed the slides very carefully.
She even brought the old records to review the slides.
There you go. So I don't know if she's a primary medicine doctor or a hematologist. So that's definition we still have to make. No, I'm just kidding. But she's a good physician. Okay, so for our case number 3, we have a 25-year-old male with sickle cell disease present with a crisis. That's what the ER tells you. The history indicates the presence of leg swelling, cough, shortness of breath, chest pain, but the patient tells you, this is not typical of my pain crisis. That should immediately ring alarm bells. Although the history doesn't reveal features that may have provoked a VTE, you may think now of the epidemiological data that suggests that many are unprovoked. You obtain a lower extremity ultrasound and a CTPA, and you are, surprise, surprise, diagnosing a right femoral DVT and a right-sided segmental pulmonary embolism. You begin anticoagulation with low molecular weight heparin, and you're going to discharge this patient with instructions to switch into an oral anticoagulation. What agent will you use? And this is a common issue that dogs, most people, would you use warfarin, would you use apixaban, rivaroxaban, would you use aspirin? Okay, we have everyone over here who knows everything about the new anticoagulants. So, okay, we'll talk about that. So some people don't want to use aspirin, some people want to use the oral direct anticoagulants, and some people don't want to use aspirin. Did someone say aspirin?
You said aspirin.
I said aspirin, but did you also say aspirin? No. Okay. Well, I wouldn't use aspirin. We'll talk about that later. There is data that it works, but not enough. So if you look at the history of agents, you can see there's multiple things that's been tried. The low molecular weights are what probably everyone in the room knows about, but there's this influx of non-vitamin K oral anticoagulants that tend to work either at the factor 10 level or at the thrombin level, dabigatran being the one acting at the thrombin level, and rivaroxaban, apixaban, and doxaban working at the anti-10A level. There are newer agents, one working on factor 11, which are very effective in prophylaxing surgery-induced venous thromboembolism, and those agents come with a reduced risk of bleeding, so those are things to keep your eyes open for. So the answer for this patient is, if we go by the ACCP guidelines, in a patient with a DVT or a PE without active cancer, the NOACs are preferred over warfarin as a grade 2B recommendation. And the reason they say that is the efficacy is almost similar. These were all non-inferior design studies, but the safety was greater, meaning that they had less bleeding at the end of 3 months. Currently, there's no single NOAC that's preferred over the other, and compared with the traditional anticoagulants, NOACs in sickle cell disease have similar efficacy and are quite safe. I will show you that data, but we'll talk about it. When you talk about how you initiate the treatment, as Katerina was talking about, apixaban, etc., require an overlap with low molecular weight heparin, whereas rivaroxaban can be started straight off. I'm sorry, both rivaroxaban and apixaban can be started straight away, whereas both dabigatran and edoxaban require a bridge with low molecular weight heparin. You can see that they are very efficacious. All of them are non-inferior to the standard, which was low molecular weight heparin. The major bleeding rates are reduced. All of them tend to require adjustment with renal dysfunction, and this is typical in our patient population, so it's something to keep in mind. So when do you consider using a NOAC? For me, if the adherence to medication is good, I would definitely consider that. If it's not good, then I would be thinking hard. If you have poor INR control, that is, if your target therapeutic range is less than 60%, I would think of switching and using a NOAC. If you had normal renal function and normal hepatic function, that's when I would consider using a NOAC. When would you avoid using any of these agents? And there I would say poor adherence, renal or hepatic dysfunction, concomitant use of a P-glycoprotein or a CYP3A4 inhibitor, pregnancy, dual antiplatelet therapy, and if you have a cancer, specifically a GI malignancy or an increased risk of bleeding. In sickle cell disease patients, 43 patients have used NOACs, and there have been only 2 bleeds, which is about 4.6% at 12 months follow-up. So I think relatively safe. I have one more case for you guys, and that's dealing with the side effects of anticoagulants. So you are paged by an ICU fellow for an urgent consult on a 40-year-old female with sickle cell disease who's undergone stem cell transplantation. She's day plus 40 on prophylactic dose. Apixaban to prevent recurrent VTE, her platelet count is 50, and she was transferred to the ICU a few minutes ago with sudden onset of headache, right-sided weakness, and loss of consciousness. You're asked to review the CT scan over here, which shows you an intracranial bleed. What would you do? Stop rivaroxaban and immediately infuse andexanate alpha. B, transfuse platelets and arrange 4-factor prothrombin concentrate complex. C, seek neurological guidance. C, okay, I like that. But if you'd said all of the above, I would have liked that too. So C is very good, because then the neurologist goes in here and puts a little burr hole and drains out that and reduces the intracranial pressure, because you can see that there's shifting over here and raised intracranial tension. But the neurosurgeon doesn't like to do that without the hematologist blessing the whole thing. And so some blessing has to take place. And so what's the bleeding risk of sickle cell disease patients with venous thromboembolism? You can see that from the California cohort in the relapsed group, 245 patients had a bleeding event. The majority of bleeding was GI, again, very similar to the cancer patients on NOAC therapy. There were quite a few intracranial bleeds as well. If you look at our patient, this patient was also on antiplatelet agents. So what is the risk of bleeding if you have warfarin with aspirin? It's twofold. If you have warfarin with aspirin with clopidogrel, it's about threefold. And these are studies from patients that have been on atrial fibrillation. So they're, again, not necessarily representative of our patient population, but suggest that there's an increased bleeding risk, like this patient who was already on aspirin. What are the treatments that you can use to reverse these NOAC agents? One is andexanate alpha, which is a factor Xa inhibitor. It targets factor Xa inhibitors by binding them. There's a newer one that's coming out, which is called siraparantag, but it's still not available. We have andexanate alpha available in our pharmacy. It's about $5,000 a pop, so it's expensive. And there's Praxbind, which is very specifically targeting dabigatran. It's a monoclonal antibody. This also is pretty pricey. And it's a single dose of 5 grams as an IV. Then we have the 4-factor prothrombin concentrate complex. Most of these are investigational, and we don't know what the risk of clotting on these agents are. But what we do know is it's not trivial. So if you give these agents to patients that have had a blood clot, there's a good chance that you might trigger more clotting. So I'm going to end here by telling you, or at least convincing you, that sickle cell disease is a hypercoagulable state. There's increased evidence for venous thromboembolism by the age of 40. There's a 2 to 3-fold mortality risk associated with developing a venous thromboembolism event in sickle cell disease. And there's a 25% cumulative incidence of recurrent venous thromboembolism at the end of 5 years. We tend to diagnose VTE very similarly to that in the general population, excepting for the use of D-dimers. I'm sorry, I didn't talk to you about clinical decision rules, which are very important in the general population, where they can help you determine what you do with your patient, rule out a PE, or rule out a DVT in the emergency room. But these are not validated in sickle cell disease patients, so I wouldn't use them. I would say the minimum effective therapy for venous thromboembolism is 3 months. I would consider using DOACs. Judiciously use that choice, because patient choice is important there, as well as thinking about the costs of those treatments. I would consider a hypercoagulable workup if people have recurrent venous thromboembolism. I didn't talk to you about that, but the typical things that I do is an antiphospholipid syndrome workup, protein C and protein S, because there's evidence that these are decreased in sickle cell disease. If patients with sickle cell disease have a single clot, I would think about extending their anticoagulation if it was unprovoked. And I would extend it on a yearly basis and always measure the risk of bleeding. You know that the risk of bleeding on anticoagulation is high in sickle cell disease patients, so therefore I would carefully monitor and reevaluate extended duration anticoagulation. I'm going to end there and say thank you very much for your attention. You are a very kind audience, and thank you for standing up and reducing your risk.
All right. In the interest of time, I think we will move on to our next talk by Dr. Susan Lewis. So without further ado, we'll ask Dr. Curtis to come up. And as you heard this morning, opioid use, especially in sickle diseases, at least in the U.S., is a little bit problematic. So hopefully she will tell us her thoughts and maybe what she can help us with.
So I'm going to talk about opioids and marijuana and sickle cell disease. So we'll start with just a brief overview about cannabinoids, and that's the main active ingredient in marijuana, how they work, why we use them, how they work in other diseases and what effects they seem to have, and then we'll move to what we actually do know about marijuana and cannabinoid products in sickle cell disease and what studies are ongoing right now. So, cannabinoids are part of the endogenous endocannabinoid system. They're very important neurotransmitters, so everybody in this room right now has cannabinoids in their body active. And what are those two cannabinoids? They are 2-AG and anandamide. Anandamide is named for the Sanskrit word ananda, which means joy or bliss. That tells you a little bit about what kind of signaling these are involved in. And there are two receptors that they act on. Cannabinoid receptor 1 is largely a neurologic receptor. It is located in the brain and in the spinal cord, and it controls most of the things that you typically think of marijuana as doing. It controls pain, it reduces anxiety, and it increases appetite. Cannabinoid receptor 2 is actually largely immunologic. It's located on the leukocytes as well as in the lymph system. It is located in the peripheral nervous system, but mostly in the glia, so that's the immunologic cells of the nervous system. It also has some locations in the gut, but similarly, that's in the inflammatory cells in the gut. And what about marijuana? So marijuana is made up of phytocannabinoids, so that is cannabinoids derived from plants. There are over 120 known phytocannabinoids, and they all have a variety of activity on cannabinoid receptor 1 and 2, as well as many other neurologic receptors in the human body. But the two most common ones, and the ones that are the most well studied, are THC and CBD. THC is commonly thought of as the psychoactive ingredient in marijuana. That is the one that makes people high, but it also seems to be the one that has the strongest effect on pain. There is an FDA-approved form of THC, that's dronabinol or Marinol, and that's approved for appetite stimulation as well as nausea and vomiting. CBD, the second most common cannabinoid, is thought of as the non-psychoactive cannabinoid. It does not make people high and mostly actually has an anti-inflammatory effect. There is also an FDA-approved version of this, that's cannabidiol or Epidiolex, that is approved for a few rare seizure disorders. Finally, not in the United States, but in many countries in Europe, there is also nabiximols or Sativex, which is an oral mucosal spray that's approved for spasticity and multiple sclerosis, as well as chronic pain and cancer and neuropathic pain, and that's a THC-CBD combo. So there are some medicinalized versions of these substances that people are studying. And what do we know about how these substances work? So there's been some nice longitudinal studies looking in the United States at what happens when a state legalizes medical marijuana. And what these states have shown is that when states legalize medical marijuana, subsequently there are reductions in opioid overdose death, there are reductions in opioid-related hospitalizations, and there are reductions in opioid prescriptions, both in Medicare and Medicaid. So states that start having medical marijuana laws subsequently have less opioid use. Now, many of the direct controlled studies that have been done with cannabinoids have been very small, they've been single center, but the National Academies did a review of these studies and concluded that there does seem to be evidence that cannabinoids do have an effect for chronic pain. And specifically and interestingly, Cochrane did a nice review showing that cannabinoids seem to be effective for neuropathic pain. That's very important both because opioids do not seem so effective for neuropathic pain, and many of our patients with sickle cell disease do complain of neuropathic pain, and so this gives us potentially an option to treat that. There are, of course, adverse effects as well, so nothing has effects without side effects. So an important one is there's an increased risk of motor vehicle accidents, so just like you wouldn't want your patient taking a high dose of opioids and driving, they shouldn't use cannabinoids and drive either. There's been studies showing that there's an increased risk of psychosis. This risk seems to be highest in daily cannabinoid users, and it's also highest in patients that already have a predisposition to psychosis, so specifically patients that already have mental health diagnoses or have had psychotic episodes in the past. There is evidence that adolescents who use a lot of marijuana during their adolescence do have decreases in brain development, show they don't do as well obtaining educational goals as adults. Now, that being said, there's also evidence that adolescents with chronic pain throughout adolescence do not do as well obtaining educational goals as adults. And we don't really know what chronic opioid use does to brain development in adolescents, so there certainly are some questions there. Smoked cannabinoids can have very negative respiratory effects, so chronic use of smoked products increases risk of wheezing and cough, and more recently, there's concerns about vaporizer use. And last, there's a rare syndrome called marijuana hyperemesis syndrome, where daily users of marijuana can develop daily severe vomiting that will only go away when they stop marijuana use. So there certainly are some concerns. Dr. Kalpana-Gupta's lab has done some lovely research using sickle cell birth mice and showing what happens if you give them cannabinoid receptor 1 or cannabinoid receptor 2 agonists. She found that cannabinoid receptor 1 agonists in these mice helps improve their pain tolerance for heat, for cold, and for pressure. She found that cannabinoid receptor 2 agonists alone only improved pressure pain but didn't do anything for heat and cold. So cannabinoid receptor 1 really seemed to be better for pain. She also found that cannabinoid receptor 1 and 2 agonists did a lot for inflammation. So they reduced the white blood cell count of these mice both at baseline and after they had a crisis induced by hypoxia. They also reduced the mast cell activation, which we think is very important in the development of pain in sickle cell mice. And they also developed reduced multiple inflammatory cytokines. So, as Dr. Heaney nicely pointed out earlier, an anti-inflammatory agent has a potential to improve sickle cell disease. What about people? What do we know? So most of the studies that have been done looking at people with sickle cell disease using marijuana are cross-sectional studies. These are mostly survey studies asking patients, what do they use? And while these studies have had some variation in their methodology in terms of what they defined as use or what other results they looked at, there are some things in common that we can take from these studies. So the first is, other than the first study, which was done in teens in the 90s, all subsequent studies have shown that the rate of self-reported cannabinoid use is pretty high, so about a third or higher. This is much higher than the average rate of use. So just for comparison, in the United States, in states where recreational marijuana is legal, use in the past 12 months is generally somewhere around 15%. So this is a much higher rate, but this rate is actually not higher when you compare it to other diseases of chronic pain. So studies that have looked at cancer patients with pain or that have looked at patients with multiple sclerosis and pain have showed similar very high rates of cannabinoid use. So there does seem to be an association there with people with pain using this substance. And indeed, when we ask patients why are they using, for the most part, pain is the first thing that patients report. They also sometimes report using for mood, and a smaller subset do report using to get high. When we ask them how often they use, it seems to be about a 50-50 split between patients that are using daily and weekly and patients that are using less often, that are using monthly or less than monthly. And so patients are using often. They say it's effective for their pain, but do we see that in outcomes? Well, the few of these studies that have looked at outcomes have not really shown a difference. So the study in the UK showed there was no difference in the severity of disease between users and non-users. This lovely study done right here by Dr. Knight Madden showed that there was no difference in pain profiles between the two groups. And Dr. Samir Ballas actually showed that while there was no difference in opioid use between the two groups, those that were using marijuana actually had a higher total admissions rate. What I think we need to keep in mind when looking at these results is that there's going to be a natural confounding from pain itself. So just like studies that look at opioid use in marijuana and find that patients that have higher rates of opioid use have more admissions, that doesn't mean that opioid use doesn't help pain. It means that patients with more pain need more opioids. The opioids aren't 100% covering all of the pain, and so those patients also have more admissions. And so I think we have to ask ourselves, could something like that be going on here? Are people with more pain more likely to use marijuana, and are they having worse outcomes because they still have worse pain? So that brings us to the question of medical marijuana and whether we should be using it. So there's a few countries with medical marijuana laws and more every day. In the United States, currently 33 states have comprehensive medical marijuana laws. Only 5 of those states actually list sickle cell disease as a qualifying condition. So sickle cell disease has really been somewhat ignored by these states. That being said, many of these states do list as a qualifying condition intractable or severe pain. So many patients with sickle cell disease could certainly be certified for medical marijuana under the definition that they have severe pain. So in my practice in Connecticut, we decided that we were going to start certifying our patients for medical marijuana when it became a qualifying condition. And even though there isn't much evidence, we decided we were going to do it for two reasons. We felt that it would really be harm reductive. So the first harm that we were worried about is that if patients were getting an illicit substance, that illicit substance was not regulated, they really didn't know what quality that substance was, they really didn't know what was in that substance, and that substance could have been laced with very dangerous materials. So for instance, about a year ago, actually in New Haven, in 24 hours, 70 patients ended up in the ED because somebody had laced marijuana with K2, or spice, synthetic cannabinoids. And people got really sick, and that wasn't something that we wanted our patients at risk of. And so we felt like if we give them access to medical marijuana, we're at least giving them access to a safer product that isn't going to be laced with anything dangerous. The second thing that we were worried about was legal issues. So most of our patients are people of color, and even though people of color don't use marijuana at any higher rates than white people, in the United States, they're 4 times more likely to be arrested for marijuana possession, and when arrested, they're more likely to be prosecuted and more likely to be given more severe punishments for it, and we didn't want that to be something that happened to our patients. So we felt like even though we know that we need more data, we need to do this to be harm reductive, to give our patients a safer product and to give them something that they won't have legal problems for. So this is important. When medical marijuana certification is done by a group, we are not prescribing that substance. Meaning, all we do is certify with the Department of Consumer Protection, yes, patient X truly has sickle cell disease. After that, the patient has to do the work. So they have to pay a $100 annual fee. They have to give proof of residency and an ID to the Department of Consumer Protection when they get their card from them. They then take that card to the dispensary. So the doctor doesn't have any control or even any information about what the patient is getting from the dispensary. What kind of products are they getting? Is it smokable? Is it edible? Is it more THC, more CBD? How strong a product are they getting? So all of that's completely out of our hands. It's something that the patient does with the dispensary. Once we had been doing this for about 2 years, we decided we wanted to do an analysis of what kind of effects we saw. So just to give you some sense of our size, we see about 225 adults annually. And we did an analysis 6 months before their certification and compared that to 6 months after their certification. So 52 adults at our center in those 2 years requested certification. We agreed to certify 50 of them. Of those 50, 29 accessed medical marijuana, 21 didn't. About 2/3 of those patients said that the $100 fee was just too much money for them. They weren't able to put that together, especially for a substance that they could buy off the street for free. And another third of our patients said that the paperwork was really difficult, getting multiple forms of identification, sending it all to the DCP was just too hard. So we compared those 29 patients that accessed medical marijuana to the 21 that did not. We also took a random selection of 25 patients from our clinic that had been there in the past 2 years that did not request certification to see if there was any difference in patients that requested. We found that there was no difference in age, in gender, in likelihood to be on hydroxyurea, or in private insurance. Interestingly, we found that those that did not manage to access medical marijuana were more likely than the other two groups to be of the less severe genotype, SCS beta thal plus. And we found that both groups that requested medical marijuana were very likely to have previous marijuana use, whereas the group that did not ask to be certified for medical marijuana had very little previous marijuana use. When we looked at their outcomes before certification, so this is quartile, so the median and the 25th and 75th percentile, we found that the three groups had no difference in admissions, in ER use, in infusion center use. We did find that both groups who requested certification had higher baseline opioid use. The group that did not request certification had very low opioid use at base. And once they were certified, so this is a waterfall plot. So this is showing the difference in the next 6 months from the previous 6 months. So each bar represents a patient. Flat bar is no change. Increase shows an increase in admissions in the next 6 months, and a decrease bar shows a decrease. So those that did not obtain medical marijuana, their admission rate was either flat or slightly increased. It was an average of about 0.5 admission increase in the next 6 months. Whereas of those that did obtain marijuana, 40% of them showed a decrease in their subsequent admissions. So this ended up to be an average of a drop of about 0.6 admissions in 6 months, and the difference between these two groups was statistically significant. There was no differences in ED use, infusion center use, or opioid use, which is a little surprising to us. That actually stayed pretty flat for all three groups. And just for comparison, the group that did not request certification, their admission rate stayed very flat. So it was an average of minus 0.1 admissions with a standard DEEP of 1.2. So they really didn't show much change either way. When we asked our patients, how often are you using and what are you using? What we found is that those that were certified for medical marijuana didn't use any more frequently than they had previously. Daily users were still daily users, monthly users were still monthly users. But what did change is that they were much more likely to access edible products. So even though at both times they did use a fair amount of bud, and I will note that whether you're purchasing illicit or from the dispensary, this is simply the cheapest product. But once they obtained medical marijuana, they used a much higher set of edibles, of vaporized products, and of oils, which they would generally cook themselves at home. So, in summary, at our center, we found that those that request certification for medical marijuana were very likely to already be marijuana users and had higher rates of opioid use than people that didn't request medical marijuana. And we found that certification and accessing medical marijuana was associated with a reduction in admissions, no change in opioid use, but a higher rate of use of oral products. Now, of course, ultimately, if we're going to recommend anything to our patients, we would like to have a controlled study of a regulated substance so that we can know exactly what that specific substance is doing. So there are a few studies going on right now. So this study is done in California. It's actually completed, so I'm really hopeful that they'll report their data at ASH this year, but we'll see. So they used a vaporized 1-to-1 THC CBD blend. Patients were admitted for 5 days and were given the inhaled product while they were admitted. This was a crossover study, so every patient agreed to be admitted twice, and one time they got placebo and one time they got drug. The primary outcome of this study was pain level, though they also did look at inflammatory markers as well to see if that same murine anti-inflammatory effect would show up in people. At Yale, we're doing a somewhat similar study. So we're doing a study of dronabinol. So that's that FDA-approved oral pure THC-containing agent. So we like that it's FDA-approved, and we like that it's oral. We really would like our patients to avoid smoked products if possible. Similarly, we are doing a crossover study. So there are 2 treatment periods. Each one is 2 weeks long. Patients will receive dronabinol during one of those treatment periods, and they will receive placebo during one of those treatment periods. And though we are looking at pain outcomes as well as other quality of life outcomes like sleep and anxiety, as well as inflammatory markers, our primary outcome is really feasibility. Because before we turn this into a larger study, we'd really like to answer some questions such as, can we actually blind patients to a psychoactive substance? And will patients use other marijuana-containing products while using dronabinol? Or as we ask them, will they avoid those other substances while on study? So we'd like to answer those questions first and then hope to design a larger study from there. So in summary, in patients with sickle cell disease, marijuana use is very common. 1/3 or more of adults with sickle cell disease use marijuana. When you ask them why they use, they mostly use for medicinal reasons, for their pain, sometimes for their mood. Those who request medical marijuana are likely to already be users and likely to have a higher opioid dose. Obtaining medical marijuana, at least in our single center study, was associated with a reduction in admissions and a higher use of oral products. And there are controlled studies ongoing. So what can we conclude from that? So the first thing I would conclude is that we should be asking patients about marijuana use. So even if you live somewhere where you can't certify patients for medical marijuana, asking if they're using, A, gives you a chance for education, to talk to them about safety issues like avoiding smoked products or being careful with driving. And it also, we've found, sometimes gives us an insight into things that we didn't necessarily know were going on with our patients before we talk to them. Sometimes our patients say, yeah, actually I'm using it for sleep, or I'm using it because I'm getting a lot of anxiety. And these might have been symptoms that we hadn't necessarily recognized before, and so it gave us a chance to better understand how our patients were doing with their health. If you're in a state that does have medical marijuana, I would consider offering it to your marijuana users. Even though, once again, we certainly need better data, you're giving them a safer substance and you're letting them avoid legal issues. So this is really harm reductive. Third, I would consider advocating for legal parity. So most states list that people with cancer pain can access medical marijuana. And I think we feel that, as we've seen in the opioid crisis, people with sickle cell disease are a very special population with very complicated pain, and they similarly deserve special considerations. So I think if we're going to say that somebody with cancer and pain can get medical marijuana, then we should say that somebody with sickle cell disease and pain should have similar access. And finally, I want to emphasize that I think we really need more studies on the effects of these products. You know, this is something that a third of our patients are using, and yet we know very little about its effect. I think if so many of our patients are using this and think that it benefits them, then it really behooves us to find out, does it benefit them? If so, why? And how can we really maximize this and give this to them in the safest and most effective way possible? Thank you everybody for your attention, and I'd be happy to take questions.
Again, I think I'll reserve the questions for the end. And our next speaker is Dr. Dabari, and she'll talk to us actually about the concept of pain as being complex in the context of sickle disease. And I think it follows very well from the previous talk.
So I'm going to talk about pain, and talk about pain is just a symptom which is so common in our population, but there are different reasons for that. So pain, this is kind of outline of my talk. So I'm going to talk a little bit about pain, different etiologies of pain in this population. What are the different phenotypes, and how can we use recent criteria, those have been described, to see which pain phenotype your patients may fit. And it's important to identify what kind of pain patient may be experiencing, because really response to therapy is determined by the phenotypes. So pain is the most common cause for hospitalization for our patients. It leads to significant morbidity, not only in terms of cost, but also quality of life, and it's associated with early mortality. So their phenotype of pain is, they are diverse in sickle cell disease, and we are very familiar with the acute phenotype of pain. So when the patients are young, starting at 6 months of age, they start to have pain, which is the classic nociceptive kind of pain. And what it means is they have all the signs of inflammation. So the area looks red, this tender, it's painful, and it's precipitated by certain factors. We also know, as you saw this cartoon earlier today, although the sickle cell is in the center of all this vaso-occlusion, other cells are also very important and play an important role in pathology. So you saw that earlier, like white cells play an important role, endothelial cells, as well as different mediators. And that what happens here is it leads to ischemia, reperfusion injury that also you saw earlier. So there's occlusion of the blood vessels that leads to hypoxia, and then when there's release of occlusion, that leads to reperfusion and the inflammatory state. And those are the mediators that stimulate your nociceptors, and that leads to pain. So next is, like, although we have known about pain for a long time, but there were no really diagnostic criteria. We just realized when patient says, I have acute pain, we thought it's vaso-occlusive pain or acute pain. So recently, this year, these criteria were described, and I think these are helpful for when we provide management or manage our patient's pain. So these were published this year, and you can access that through the Journal of Pain. But I have highlighted some of these things here. So what are these criteria? So we know a patient has to have sickle cell disease, pain, and this was just consensus. If the pain is lasting for more than 2 hours, it probably is related to the vaso-occlusion, and there were certain signs. But I think the important part of this classification was the modifier, because really that affects our management and the outcome in our patient. So acute pain that occurs in presence of chronic pain is different from acute pain that occurs in absence of chronic pain. So when you see the 6-month-old child or the 1-year-old child who has acute pain and hasn't had chronic pain, that is different from your older patient who may be 30-year-old and has acute pain in the background of chronic pain, because their response would be different. So next is, as our patients, so I showed you the first picture, the classic acute pain, and then as the kids get older, they start to have more and more pain, and typically we see this transition in the teenage years. So they still have acute VOC pain, but also you would see the interval between two pain episodes may be going down. Sometimes the pain may not return to the pain scale of 0. They continue to have daily pain. And the same thing is shown here. Here is the age group and total number of discharges or admission and their length of stay. So as you can see that when the child is less than 1 year old, the total number of admission were very small for pain, less than 2%. Length of stay was small. But as the kids get older, especially over 18, they were responsible for 60% of the episodes of hospitalization, and length of stay was also longer, so about 6-day average. And this is also was shown by the epidemiologic studies showing that as the patients get older, chronic pain or daily pain goes higher in rate. So it's so much so that more than 50% of the patients are in pain more than 50% of the days. And 1/3 of the patients have pain pretty much every day, so more than 95% of the days. So it just shows the chronic pain is very common, but also, so when we see our patients for hospitalization or in ED, we are just seeing the tip. Patients may be experiencing pain, but they may not be coming to the hospital. And so chronic pain, why do we get chronic pain? So chronic pain can be because of multiple causes in adults or in pediatric population. Sometimes it could be gallstone, sometimes avascular necrosis of hip, leg ulcer, or sometimes there are multiple sites of pain which we really cannot explain why these patients have pain. So similarly, this need was identified by the American Pain Society, and it was a group of people were invited to develop the diagnostic criteria for chronic pain. And this was the result. And here again, I'm listing and these were called AAPT criteria for chronic sickle cell pain. And these are listed here, the highlights are here. So obviously presence of sickle cell disease, pain, and also comorbidities in this population becomes very common. So patients who have chronic pain, sleep disturbances are common, anxiety and so on, other things are quite common. Again, I think modifiers were very important here. So the three kind of chronic pain were described, or the modifiers for chronic pain were described. So these were chronic pain when there is no contributory sickle cell complication, meaning your patient has multiple sites of pain, but really we cannot say why this person has pain in these areas. Second was chronic pain with contributory disease complication, meaning if a patient has hip right AVN or avascular necrosis of hip, the pain is on the right side of the hip. And the third was mixed pain phenotype, meaning you have hip pain also, but then you have other pains like migraine or shoulder pain or abdominal pain, which cannot be clearly identified what's causing it. So it's easy to think like why a person who has an AVN of right hip should have pain in the right hip. But what's happening with other populations, especially when we cannot explain why the person has pain, or we cannot explain why the person has mixed pain phenotype, meaning some of the pain can be explained, but other pain cannot be explained. So these probably are because of indicate the neuroplasticity. And the good thing or the bad thing about neuroplasticity is we are born with certain pathways, but they may change over time. So either they can go in good direction or in the bad direction. So what happens in sickle cell, it's proposed that when you have repeated nociceptive input, that can in the end lead to the central sensitization. And by central sensitization, it means is you are very sensitive to the painful stimulus. So you need just a smallest amount of the stimulus to lead to pain. So in the physiologic terminology, that is called that lower threshold. So there's lower threshold for pain. People may have spontaneous pain. And also the third thing is the enlargement of the receptive field. So you no longer have pain in the area where your pain started. The pain may involve other areas and is the indicator of central sensitization. And there are multiple steps for that, and I'm not going to go in detail, but the changes, and I'll show you the evidence for these findings. So there are changes that happen at the effector level, there are changes in receptor, there's change in transmission, and this is the end result. So these changes, again, the central sensitization is the increased responsiveness to painful stimulus, and these are certain changes. So you can see the changes at the peripheral level and all the central level, as well as the dorsal root ganglion. So do we see those in sickle cell patients? So here, these are some of the tools that can be used for looking for the pain sensitivity. So you can give a standard stimulus to every person and see how is their response to pain. So we use some of the tools and examined sickle cell patient and looked at these patients were, one group was adults with sickle cell disease, other group was the control. These were the age and gender matched patients who didn't have sickle cell. So here you can see, So here you can see that patients who have sickle cell disease, they were more sensitive to pain. So even at the, not only when you lower the temperature, they started to have pain at sooner. So they were more sensitive to pain, and also they had spontaneous pain. And the way to look at that is a test called temporal summation. So what you do is like you use a sharp stimulus and give it to patient and stop after a while. So once you stop, if you don't have central sensitization, your pain should go away. But if you have sensitization and spontaneous pain, you may continue to experience pain for a longer duration. So what we saw in patients who had sickle cell here, they continue to have after sensation for a longer duration compared to the controls. Then what about the changes in the brain? So it's easier to do in mice where you can, dissect the mouse and look at different things. But in human, thankfully, we have the methodologies where we can examine the brain, so like functional MRI. And we looked at the population of patients who had either high burden of pain or the low burden of pain. So in our brain, there are certain areas when these are stimulated, they lead to pain, and there are certain areas when they are activated, there's pain relief. So these areas are called nociceptive area, which lead to pain, and anti-nociceptive areas, which reduce pain. So patients who were in the lower pain group, they had connectivity to the anti-nociceptive area. And the patients who have higher burden of pain, they had more connectivity to the nociceptive area. And it's just like a cross-sectional study, but I think it's important to see, were these patients born this way? Because we know in general population also, there are people who are at higher risk for experiencing more pain. So what I have shown you so far is when the child is young, there's acute pain phenotype. Pain is mostly focal, and vaso-occlusion is the primary mechanism. And there are certain triggers which we know, stress, weather, and so on. But as the patients get older, the pain frequency increases. And along with vaso-occlusion, other mechanisms start to become active, like central sensitization, peripheral sensitization, and also I want to point out the chronic pain modulators. So like stress is always important, but depression, anxiety, and sleep, they are all connected when you have chronic pain. So it's important to pay attention to that. Is it important to know what kind of pain phenotype your patient may have? And we all have patients who may be on chronic transfusion and very small amount of sickle hemoglobin, but continue to have pain. And so it's important to know what kind of therapy to use for this population. And we had examined at the NIH with Suile and Matt and John, looking at the patients who were cured of their sickle cell disease with bone marrow transplant, and we looked at their pain outcome. So it became clear that patients who had mixed pain phenotype, or where we could not explain their pain before they went into transplant, they were at higher risk to continue have pain after the transplant. And this was just at the end of 12 months, because neuroplasticity, maybe it just takes longer time for the resolution of pain once you're cured of your sickle cell. So you have probably, you saw part of it earlier today. So these are the guidelines how to manage acute pain for patients with sickle cell disease. And really, because it's primarily nociceptive pain, so anti-inflammatory like ibuprofen or ketorolac, they work pretty well. Similarly, opioid work pretty well for this kind of pain. But once you have chronic pain, it's important to individualize the therapy, because one person's pain may be totally different from others. So you have to, and also pay attention to the comorbidity. So sleep is important and management of anxiety and depression. So really multidisciplinary approach is the key for this population. Also the attention to non-pharmacologic adjuvant therapy should be given because there are certain other things which really have not been tried in sickle cell a lot, but I think we should look into that as well. So this is this slide summarizes what to do in patients. So here, the adult patients who had more admission, so likely indicating that they have chronic pain, they should get special attention. So examining, looking really what is contributing to their pain is important. So focus resources on adults who have chronic pain. Then second thing is, first, it's all started with a sickle cell. So it's important to manage their sickle cell. So it's important to maximize their hydroxyurea use, chronic transfusion, and fix what can be fixed. So if a person has AVN, that needs to be fixed. If they have gallstone, that needs to be fixed along with their sickle cell disease. And the third thing is, when we manage the chronic pain, so we need to use the sickle cell principle, but also need to use the principle of managing chronic pain. So for example, use of opioid. So because there's evidence showing that opioid use, high opioid use can also lead to central sensitization and increased pain. So it's important that we pay attention to opioid use, and really higher dose and more opioid may not be the answer. So we need to the smallest dose that is possible to control pain should be used. In summary, hopefully I have showed you today, is the pain is the most common symptom, although exhibit different phenotypes in patients with sickle cell disease, and these mechanisms are different, and all the mechanisms are not same. So all pain is not same in sickle cell disease. And it's important to also understand that one or more mechanism could be active at a given time. And this becomes very important when a patient with chronic pain go to the emergency department for acute pain, because you can have acute pain on chronic pain as well, and that needs to be managed as well. Diagnostic criteria that I showed you, AAPT and AAPT, are useful, at least can assist you in diagnosing the pain phenotype, and principles of managing sickle cell as well as pain management should be utilized for better control of pain. And that's it. Thank you.